But first of all, I'd like to thank the Urology Association not only for organizing this outstanding meeting. This is really we surprise with best quality everyone from every preparation. And just continuation to Dr. Ilawi said, Kuwait was starting from the beginning to be involved internationally and regionally, to be a part of the founder of the Arab Association of Urology. On behalf of the Arab Association of Urology today, I can say that the Kuwait Urology Association in the last 10 years is one of the best sustainable associations actively participating in the whole activity of the Arab Association of Urology, not only within the Kuwait, but also in different Arab countries. Actually, I was planning to give a lecture about the history and the activity of the Arab Association of Urology, but actually I changed a little bit, so I'd like to touch an interesting topic, which is day and day or bread and butter for any urologist in his daily clinical practice. So I'd like to, because this is one of our projects of the Arab School of Urology, we want to reach a consensus about how we can manage the asymptomatic, non-obstructing PCOS. It's really controversial how we can manage asymptomatic, non-obstructing calcium stones. It is to treat or not to treat. It's a doctor decision or a patient choice, because all of us know that the advantage or the progression of the diagnostic modalities becomes very strong, different than the previous years. Ultrasound now in each clinic, in CT scan is available in many cases. So we are facing a lot of cases that accidentally discover that the patient has a stool and he's asymptomatic. And we did a quick survey in different countries to see how utilization of these new diagnostic modalities. So ultrasound has been used in more than 34% of clinics of urologists and other specialties just as a part of clinical examination. So this is the reason why we are discovering more and more asymptomatic stool. So look also to the CT scan, how many cases of accidentally discovered stool during CT scan, it reaches up to 18% that you can get asymptomatic accidentally discovered stool. So here it comes the question to treat or not to treat. And the rationale behind it that if you are going to treat, because there is theoretically stones can grow up, stool can induce infection, stool can induce symptoms, so you have to proceed for active management, which is logic, rationale behind that. On the other side, not to treat also has supported that if this patient is symptomatic, he is not a patient. And if you do a procedure for him, you may induce some symptoms, some complication, unnecessary procedure, in addition to the possibility of spontaneous death. So each decision has its pros and cons, and it's a controversy. How to support, to treat or not to treat, this is the challenge. We'll go through the literature and we will see how those kind of patients respond. And this is one of the largest study published in the Urology Journal. It's follow-up for up to 3 years, and they found only 25% of those patients are requiring the intervention, and the majority of them, they not require surgical intervention. Another study with the same 3 years of follow-up, and showed only 19% require surgical intervention. And here we can see around 11%, 7%. So minority of those patients require surgical intervention. And even in this one study, in the first 2 years of follow-up, no single patient required any intervention. And the possibility of spontaneous specialty is not small, it's each 20% of those patients can have spontaneous specialty. So now we think if we actively treating those patients, so majority of them cannot need this to be considered as unnecessary. But if we look why to treat, again, because the stool can grow up size, stool can induce symptoms, and stool special categories of patients, especially those elderly or those with other comorbidity, maybe need a follow-up to go. So we don't have even a consensus how to follow up those patients. You decided not to treat the patient, and you just follow up. When he will come to you, how frequent he needs, how many investigations you should repeat, to be sure that this patient doesn't develop any complication. And then, if you decided to treat this patient, will come the choice how to treat, either by shockwave, or by flex, or retroscopy, or by smear. So different modalities of treatment and how you select. And we look to the guidelines based on the stone size. If you will go for shockwave, you have to look to the favorable criteria of cranial anatomy or the local bone different in the middle view. So it's another dilemma that if you want to treat the patient, which patient and how to select. And look to the complication that happens, although flexible retroscopy now is routine and basic working in all of our centers, but still we have significant percent of complication can reach to up to 14% and 6% can be considered as a major complication. If we compare the scar that happened after shockwave and BCL, if you are treating larger stone in the calyceal system, so you can found that scarring happened with the shockwave higher than with the BCL, so you are exposing the patient to renal scar, and you may not get the patient stone-free after shockwave, especially if it's in lower calyceal stone. So we have to think seriously about those patients asymptomatic, discovered accidentally stone, if we are exposing them to a surgery, and we may develop some complications, side effects, and it will go into a long sequence. So what we wanted to say, to have decision about active management, you have to be a shared decision. You have to keep in mind the risk and the benefits for this in prevention, and you have to think about patient preference. It should be a shared decision. Patient job, patient function, if he is traveling, if he is vital, if he has something can put him at risk of keeping the spoon without an active management. And you have also, when you decide to treat the patient, give him the realistic expectation, because he may know if he comes with a spoon 10 millimeter, he may have a residual of 4 millimeter. So the realistic expectation of the patient that he may not be spoon-free, or he may need a special procedure to avoid troubles that it can happen with the patient and his physician. And if you look at the European guidelines, and we believe this is more appropriate to be utilized, however, we cannot do that to our region, that observation is recommendation for asymptomatic calyceal stones and preserve the treatment only for symptomatic threats. We believe this should be the best clinical practice that we should adapt, and we have to follow up in our region. However, still further study, and this is what we as the research committee in Arab School of Urology are working to have a design of the study, and will be shared with all Arab countries very soon to have the opinion, the feedback, how many cases you discover that in reality, how you treat, are you going for an active treatment or you go for conservative. We need to build the consensus because the patient in our region is different than it comes from the Europe or United States. We have a different mentality. Our patients may not accept to stay with a stone. If you advise him for observation, he will not live with a stone in his body if you want to get rid of it. It can be the reason why you are actively treating the patient. So hopefully, if we can soon we can distribute this study, it will be very helpful to reach to a consensus how to treat such kind of patients in our region. Before leaving the stage, I just wanted to remind you with the Arab Association of Urology upcoming activity during the 2023, and we are starting in March, is running the usual routine, the joint session with the European Association of Urology that will be in Milan in March 2023, and we have the IOCC conference that will be in Abu Dhabi in May, which is a multidisciplinary meeting with interested to gather urologists with other relevant specialties. And we have the biggest event with the collaboration between the Emirates Urological Society and the Urological Association of Asia. That will be a big gathering that will happen in Dubai next September. And the most important, that we will be here again next year. The annual conference of the Arab Association of Urology will be joined with the Kuwait Urological Conference to be hopefully one of the best versions of joining the conference. It will be in November next year in Dubai. Again, also I'd like to remind you that the individual membership of the Arab Association and the Arab School, because we have focusing next year, 2023, to direct our activity to help the young urologists in training and improving their skills and knowledge through different activities in hands-on training, wet lab or cadaver lab, as well as we are improving and enhancing our e-learning platform. The new version is coming in January 2023 that will provide a lot of educational materials and providing the CE required for everyone. Last but not least, I'd like to appreciate the effort that has been done during the last year by Dr. Abdul Zaroni, the president of the Arab Association of Urology, with his great effort in support to grow up the association. At the same time, I'd like to welcome and congratulate Dr. Adel Ahmadian. He is not with us today, but he will be the upcoming president in January 2023, and I wish him all the best and all the luck. Final word, I'd like to continuation to Dr. Khalil Al-Awadi said, and I always say that every time, either he is with us or not, Professor Hassan Abu Ghani, he is one of the founders and he is the one of the key persons who have the vision to gather all Arab under the umbrella of Arab Urology. We learn from him a lot, and hopefully that we can continue the mission and the vision that Dr. Hassan Abu Ghani. So please give a hand. I'd like to thank you all again, and I hope to enjoy the rest of the meeting.